Hello and welcome everyone. My name is Dr. Fernando Verdugo. I'm a board-certified periodontist, and today we'll be discussing some of the reasons why we see implant failures, bone loss, and biological complications around our implants. Hopefully by the end of this presentation, we'll be able to figure out ways to prevent these complications. My doctoral thesis, published years ago, dealt with intramembranous bone, intramembranous osseous transplants, and as you know, is the gold standard of bone transplantation within the maxillofacial complex. Intramembranous bone maintains better the volume. One of the reasons is the ossification and the embryological origin. The defects within, intraoral defects within the maxillofacial complex have basically the same embryological origin as intramembranous bone. And the ossification is direct. So basically the bone or the ectomesenchymal cells convert directly into bone, as opposed to endochondral bone, which needs that intermediate stage of cartilage formation to become bone. Endochondral bone belongs to the long bones, basically from the hip, the femur, and the tibia, and so forth. The other key aspect in bone regeneration is the periosteum, which is considered a central mediator in bone regeneration. That is another one of the key aspects that we'll be discussing throughout the presentation. And basically, we have a track record of publications dealing with the uses of the periosteum to regenerate bone. One of the latest articles that we published was on periosteal-guided bone regeneration on severely damaged sockets with simultaneous implant placement within the anterior maxilla. So when we see these are two similar cases, well, different but similar in a way, they are two central incisors, two right central incisors. Implants were placed years ago, the one on the left over 21 years ago, and is considered a success. The one on the right is considered a failure. Still, after 8 years, the implant is hanging in there. So let's dive into some of the clinical reasons why these implants are considered a success or failures. These are the clinical pictures of the case that we just saw you radiographically. The case on the left, again, is considered a clinical success, healthy peri-implant tissues, healthy bone, good radiographic bone levels, no bone loss. The case on the right, we definitely see that something is going on, a peri-implant abscess with suppuration, bleeding upon probing, and significant bone loss. So why this case, the case on the left, is considered a success? Well, one of the reasons is the implant is fully osseointegrated, and the surrounding tissues are healthy because the surrounding bone around the implant is healthy. So I would say that we have, if not 100%, close to 100% of bone to implant contact in this particular case. So let's dive into some of the reasons why we see these failures. Number one, I would say that I see that there's many times we see bone loss and lack of osseointegration associated with implants that had received bone substitutes. So the lack of new bone formation seems to be a significant factor in failure and implant complications, biological complications. The other one that we could discuss as well is bacterial contamination or infection that could lead to also unhappy tissues, abscess formation, and so forth. The prosthetic design, it is also important. There is a number of research publications leading us to believe that the prosthesis, the implant supported restoration, is key in maintaining health. Also, another risk factor that has been mentioned in the literature quite often is the excess of cement. So we could argue whether cement retained restorations can lead to more biological complications or not. We will dive into that in a minute. These are, again, two different cases. I will be showcasing different cases, and we can discuss the reasons why these cases are considered a success or a failure. The case on the top was Basically, the patient had lost those lateral incisors, had severe bony defects, and that had to be reconstructed following the principles of periosteal-guided bone regeneration. That's what we did. And so after 14 plus years, this case is definitely considered a success. Those implants placed in the lateral incisor positions are fully integrated. Definitely, there is 100%, if not 100%, close to 100% bone to implant contact. Radiographic bone levels as well are excellent. We will showcase this particular case later on, and we can discuss some of the reasons why this was a success. On the bottom, this case was considered a failure. The lateral incisors had some deep pockets, bleeding upon probing, and obviously some aesthetic issues. If I make an analysis of the literature and some of the reasons why we see failures, it brings my attention the fact that certain procedures done to regenerate bone intrasocket can lead to actually less new bone formation. When there is less new bone formation, we're going to see a compromise osseointegration. And why does this happen? This is another case. Implants were referred to me because there were some issues with their tissues and obviously aesthetics as well. The patient had deep pockets, suppuration, severe bone loss, and those implants were in the process of failing. So as you can imagine, this is what we see quite often. And so the case was done years ago by a different professional, and a number of biomaterials were used to reconstruct the anterior maxilla. I am finding quite often a lack of new bone formation, especially in the anterior maxilla when certain procedures are performed. And again, another case showing basically the similar trend, a case that was done by a competent periodontist, lack of new bone formation, and those implants failed to integrate. So definitely the bone to implant contact here, the lack of osseointegration is key. And why is this happening? We're going back to the case that we saw at the beginning, the central incisor. This case presented the patient wanted to save the implant by all means, but if we analyze this closely, we see a number of risk factors. On the one hand, we see an excess of cement. This was a cement retained restoration. We also see traces of calculus on the adjacent teeth. But all in all, we see that this implant lacks full osseointegration, or in other words, the bone to implant contact is very, very limited. I would say that, well, the osseointegration happened only at the most apical portion of that implant. And even though the implant was stable, it was basically holding a situation of disease. So in the end, we decided to remove the implant and start all over again. So again, we can ask ourselves, what are the risks of implant failure? Is socket grafting or not done properly socket grafting a factor that could affect peri-implant health? If we have time, there's a beautiful letter article that was published in Clinical Implant Dentistry and Related Research back in 2017 by Becker and Tibbetts. And they dive into some of the reasons why we see so many complications. In this particular today's lecture series, we'll be just discussing some of the few factors, although, of course, as you can imagine, there are a number of factors that could contribute to such failures. But one of the trends that I see more and more in private practice is the lack of facial bone formation. And many times this is associated with the use or the abuse of certain biomaterials that could impair new bone formation. let's take a quick look at what happens during the wound healing process after a tooth is extracted. As we know, there is different stages of bone formation from the osseous coagulum at the very beginning. One of the key phases is which I like the most, is the one that happens usually around the 10th week after the tooth has been extracted, because it's when woven bone starts to become a more mature bone. Is when we see the osteoblasts are basically peaking within that socket. And so all the mesenchymal cells, all the good stuff is happening during that time. That proliferative phase could be reduced, shut down, or impaired depending on what we do with that socket. So let's dive into the anatomy of wound healing within that socket. When a tooth is extracted, a coagulum is formed, and there is going to be an Apico-Coronal new bone formation. So meaning that the strongest bone fill occurs at the apex of that socket. And as we move towards the crest, there is less potential for new bone formation. So we have to be aware of the situation so that the crestal bone is intact. We have to favor and enhance, especially at the crest, because it's the most aesthetic area. We want to enhance that. We could see more aesthetic complications if that crestal aspect does not have healthy bone. So this is another case, a second mandibular molar. This is one of my referrals. The implant was placed by my referring dentist on a socket that had been previously grafted. The dentist waited a good amount of time, 9 months, before placing the implant. The implant failed later on. This was considered an early failure. So again, if we look at the anatomy of that socket, what happens after the osseous coagulum starts to form is key for new bone formation. New bone formation basically can be shut down, reduced, or diminished if something, the plug, is placed into that socket. And depending on how we place the plug or how we place that biomaterial into that socket, that could definitely make a difference. That socket will have definitely impaired new bone formation, and that implant will be surrounded by less bone because of the reduced new bone formation. So especially, again, we see more crestal bone loss because, like I said, the depth of the pocket, or the depth of the apex, is what determines the amount of new bone formation. So if you take a look at the case that we saw at the very beginning, again, the anatomy of that alveolus, more bone, new bone formation, more bone fill at the apex, and again, the Apico-Coronal new bone formation travels from the apex to the crest. We are going to see that by placing a biomaterial, that socket will have diminished new bone formation, diminished osteogenesis, and as a result, we can see that the bone to implant contact later on in life may be jeopardized. This was a late failure. This implant lasted for about 8 years, but basically the implant was probably being held by the apex. The only area that I saw bone to implant contact was at the apex, because the defect was traveling all the way to the most apical portion of the socket. So these are the two clinical scenarios. Imagine a socket that does not have any grafting. We are going to see, again, the osseous coagulum formation and new bone. A socket that receives any type of grafting, we're going to see, and histological human data has shown that there is less new bone formation. And basically, this is something to consider. We need to be aware of this situation, especially if we are in favor of grafting the socket with biomaterials. On top of this, we know that a traumatic extraction can lead to more bone loss. The facial bone is definitely the most delicate. There is a delicate balance between new bone formation and so forth, and we already saw the potential for diminishing new bone formation that happens after a socket is grafted with any biomaterial. So when a tooth is extracted and the implant is placed, we have a delicate balance, especially when the buccal bone is thin. We can have, in addition to less intrasocket new bone formation, we can also have some facial dehiscences that can lead to biological complications, and that is one of the reasons we see also recessions and aesthetic issues with implants that have been placed a long time ago. All in all, what we see by reading all the literature is that human histological data has shown up to 60% reduction in new bone formation when a socket is grafted with a bone substitute. And there is some very interesting human histology in this regard. Overall, again, all in all, depending on the grafting material that you use, we are going to see less intrasocket new bone formation when the socket is grafted with a biomaterial. Some are better than others. My reading from the literature definitely is that xenografts seem to lead to significantly less new bone formation than allografts. And specifically at the crest, again, we're going to see way less because of, again, like we discussed, because of that apico-coronal potential of new bone repair after tooth extraction. This was a recent study published. It's a beautiful study published with also human histology and scanning electron microscope data and micro-CT, showing basically the same thing. There is an impact of the residual graft material in new bone formation, and the control sites, the sites that receive no grafting whatsoever, double the amount of new bone formation. So there is a limit. There's a limitation in the amount of new bone formation that we see when the sockets are grafted. If the defect is larger, these studies show with larger defects, molar areas, the authors were recommending to wait even up to 8 months before going in to place the implants. And they saw a significant, close to 70% of residual graft material together with non-mineralized tissue. So all in all, what we see is that there is a delay of new bone formation, and there is a delicate balance of bone repair when a tooth is extracted. But what about damaged sockets? Damaged sockets are even more delicate. Whatever we put in there, again, on a socket that has severe bone loss, it may impact new bone formation. And as we saw earlier, we want to get as much bone to implant contact, as much osseointegration as possible. The type of biomaterial that we place in these damaged sockets can make a difference. We can achieve, as we did in these cases, 100% new bone formation around our implants, following the right principles of periosteal-guided bone regeneration. One of the key aspects is also, as shown in this research, in this nice randomized clinical trial, the thickness of the buccal bone. The thickness of the buccal bone is key, especially in anterior areas. We've seen that on sockets that had less than 1 millimeter thickness of buccal bone, definitely the dimensional changes are significantly greater, up to 3 times greater. But the hero of all this is not whatever we put in that socket, but the buccal bone thickness. We had a nice study published on basically what we see on 95 patients. This is a clinical study. We basically follow up patients that had extractions. This is on posterior teeth, though. Extractions and implant placement, roughly an average of 12 weeks after the extraction. So the study is clinical and also tomographic. CBCT images were taken after we had measured the presence or not of buccal dehiscence. In this particular case, the premolar, we measure a dehiscence of over 6 millimeters on the buccal aspect. However, look at the CDCT data. We see reformation, repair of that buccal dehiscence, even though there's a little dip in there. The buccal dehiscence has repaired completely, and so we are able to place an implant in that is going to be fully surrounded, 100% surrounded by autogenous bone. This is one of the cases that basically we follow and enter this study, and so sound Crestal healing is key for stable long-term outcomes. We want definitely healthy pre-implant tissues. This is another case, a molar, 2 molars were extracted. You can see the CDCT data. Looks like there is no bone formation. There was a buccal bone dehiscence of 8 millimeters. And so following the principles of periosteal-guided bone regeneration, we see the formation of immature bone. Basically, we need to know how to read these CDCTs, because if we look at these sites after extraction, it looks like as if there is no bone. But in reality, there is bone, that is woven bone, under mineralized. And so we were able to, following the principles of periosteal-guided bone regeneration, we were able to regenerate the dehiscence and place those implants, and had a baccolingual width at the implant size of about 12 millimeters. This is the radiographic look before and after implant placement. And this is, again, the final radiograph with the fully regenerated bone and those implants fully osseointegrated, following the principles of periosteal-guided bone regeneration. So the key message is, well, sockets have a tremendous potential for regeneration, for repair, if we allow it to happen, and it does happen. Obviously, the extractions have to be done with care, as traumatic as possible. Those are some of the key aspects as well. But let's dive. We started with a few questions at the very beginning. Now we want some answers. We said that yes, some of the complications are related to lack of osseointegration, reduced new bone formation intrasocket that has led to basically the formation of deep pockets and preimplantitis. Bacterial contamination is actually a key as well. A socket that has been grafted with a biomaterial possibly has less potential for repair and combat bacterial contamination and infection, as opposed to having fully healthy bone surrounding that implant. The prosthetic design can make also a difference, and the excess of cement has been described in the literature as a risk factor for complications as well. So how can we compensate for those? These are our goals. Basically, we want to create a 360-degree bony house around our implant, and that can be done so that we have an implant that has good bone-to-implant contact, over 90% ideally. We want to have, this is one of the keys, to me, one of the keys for success, to have an implant that is fully surrounded by autogenous bone. We also want to have an implant that is placed ideally in native bone. If not in native bone, the regenerated site ideally should be regenerated with autogenous bone. From a prosthetic perspective, and this, again, this is not the topic of today, but there is a significant amount of literature in this regard. A poor prosthetic design can lead to biological complications. So overhangs, shoulders should be definitely avoided by all means, especially more so in the aesthetic zone, because the tissues are more fragile. And the emergence profile of that prosthesis should allow for cleanability. Definitely avoid an excess of cement, and there are techniques which can help us avoid the excess of cement if a cement restoration is what you want. I personally prefer, by all means, a screw retained restorations, because those are retrievable and is easy in the case of a need for any type of treatment. Retrieving quickly that restoration may help us treat some of the complications. But all in all, this presentation was basically to integrate the knowledge, some of the knowledge that we have, and some of the reasons why we see complications. I see more and more of this in private practice. And when we understand socket wound healing, bone wound healing, and osteogenesis, and we understand these principles of bone regeneration and periosteal-guided bone regeneration, I think we will be able to achieve success in most of our cases, if not all. I want to thank you for following this presentation, for being here. If you are interested in more information or want to follow me on Instagram, you can do so. And there's definitely much more educational content coming up. Thank you again.